the phenytoin and the phosphophenytoin. And the phosphophenytoin is simply a phenytoin, but it has a phosphate group. So phosphophenytoin is a phenytoin with a phosphate group attached, and that makes it a prodrug. So actually, the rationale behind adding this phosphate group is to increase the water solubility so that the drugs becomes more easily given through the IV route. So when you increase the water solubility, that makes the drug applicable to be given through intravenous in a more safe way. And once it is in the body, it is converted into the active phenytoin. Now, there are few pharmacological things that you have to know about phenytoin. The first thing is that phenytoin is a strong cytochrome enzyme inducer. Specifically, it induces 2C9 and 2C19. And this accelerates the breakdown of many other drugs. And this is a major drug interaction point. And that's why actually phenytoin is one of the drugs that has a very long list of drug-drug interactions. Now, another thing that you have to bear in mind about phenytoin, just to link the concepts with the pharmacogenomics lecture, we said that if the patient carries the HALA B1502 allele and they take phenytoin, they are actually subjected at higher risk of a dangerous cutaneous condition known as Stevens-Johnson reaction or Stevens-Johnson syndrome, which is a life-threatening condition that leads to severe blistering of the skin. So you should avoid the phenytoin in these patients. And we've said that the Asian race is subjected to this problem more than others. Now, another thing about phenytoin is that it has high plasma protein binding properties. It is highly protein bound. So that means phenytoin binds tightly to albumin. So if the albumin is low, that means more free phenytoin would circulate all over your body, and that makes the patient more compromised into toxicity, and that actually tips the patient into phenytoin toxicity, and therefore you must correct the dose based on the albumin levels in this scenario. And that's why, if you remember in the calculations, we said that we have something known as the phenytoin correction equation. Now, regarding the IV administration, the phenytoin actually irritates the vein walls, and it causes a side effect known as phlebitis. So phlebitis means that the walls of the veins are irritated, and to reduce the side effect, we give the phosphophenytoin. So the phosphophenytoin has much lower phlebitis side effect, which means that it irritates the blood vessels less because of its better water solubility. So another thing to reduce the phlebitis, the first thing is that we said we are going to give the phosphophenytoin rather than phenytoin. The second thing is that we want to give it in a slow infusion. So whether it is phenytoin or phosphophenytoin, always give these two medications in a slow infusion, because a rapid infusion would actually increase the risk of hypotension and arrhythmia. And an exam question, what is the maximum infusion rate for phenytoin to avoid the hypotension and arrhythmia side effect? And that is 50 milligrams per minute. So this is the rate that you have to infuse these drugs slowly. So the safe infusion rate is a maximum of 50 milligram per minute. And for phosphophenytoin, you can actually go up to 150 milligrams per minute, because remember that phosphophenytoin has the phosphate group, which makes them less irritant. So the infusion rate can go up to 150 milligram per minute. But just to be safe, to avoid these side effects, it is 50 milligrams per minute. Now, another important thing that you have to bear in mind about phenytoin, as you can see, phenytoin is one of the exam's favorite. That's why we are studying it in detail. So you have to know what is the toxicities of phenytoin as per the blood levels. So actually, phenytoin is one of the drugs that exhibit toxicities according to the blood levels. So memorize this letter, which is the toxicity of phenytoin by blood level. So let's see here the phenytoin blood levels in micrograms per milliliter. Let's say if the levels is from 10 to 20, the toxic effect that you expect to see is none, actually, because the 10 to 20 is the ideal therapeutic range of phenytoin. So again, this is one of the exam questions. What is the therapeutic range of the phenytoin? Because you know that phenytoin is one of the drugs that you have to do a therapeutic drug monitoring for. And if the levels is between 10 to 20, that means you are within the therapeutic levels and you show no toxic effects. However, if the blood levels is between 20 to 30, that means you have to adjust the dose because the patient would start to experience toxic effects such as nystagmus. And nystagmus is rapid involuntary eye movement. Also, if the blood levels of phenytoin is between 30 to 40, the patient would experience ataxia and slurred speech as a side effect. And if the levels is between 40 to 50, the patient would experience lethargy. And if the patient blood levels is above 50, actually that puts the patient into a coma and precipitate a seizure paradoxically. So the most tested exam values are these values, and you have to know that the side effects above are dose related and they scale with the blood levels, but phenytoin has also non-dose related side effects. So these are the toxic dose related side effects, which means that these side effects appear with the doses. However, phenytoin has also side effects that are non-dose related. In other words, idiosyncratic side effects, which occur regardless the levels of phenytoin. And these include the gingival hyperplasia, as well as the hirsutism, and the acne, and the rash, and the hepatotoxicity, and the purple glove syndrome. And this is an exam question. So purple glove syndrome is an idiosyncratic side effect that happens regardless the levels of phenytoin. They can happen even at the therapeutic levels. And the purple glove syndrome, memorize it, is that it correlates with the drug phenytoin, and it's a condition where the palm literally turns purple after the IV administration of phenytoin.